Okay, good evening, everyone. Chapter 8 would be nursing care of women with complications during labor and birth. So it's important to remember that at this point, we are still talking about the woman during labor and birth. One procedure that we do for the pregnant woman is what we call amnio infusion. Amnio infusion is the infusion of the normal saline into an intact membrane, like a bag of water, to kind of like mimic the function of an amniotic fluid. So we use this for what we call oligohydramnios. Oligohydramnios is when there's less than the usual amount or the normal amount of an amniotic fluid inside the amniotic sac. And for those patient that has an oligohydramnios, they are at a high risk for what we call an umbilical cord compression because like we talked about in class, if there's not enough amniotic fluid, then that umbilical cord has no buoyancy or there's no fluidity of that movement of that umbilical cord, so there's a risk for umbilical cord compression. And then we talked about the variable decelerations. For your veal chop is the cord compression. V is for your cord compression. So we're trying to correct that variable decelerations. And then we can also do the amnio infusion to kind of like dilute the amniotic fluid for those meconium stain. So if the baby actually had that meconium, that first stool, while they're still inside the womb, then we can use amnio infusion to correct that. And then also it replaces the cushion for the umbilical cord and relieves the variable deceleration, like I just mentioned. Induction and augmentation. Induction is the intentional initiation of labor before it begins naturally. So this is when the physician actually is the one that initiates the labor and it's not actually because of the natural process. And then we have augmentation, which is what we do when we stimulate the contractions after they have begun naturally. So that's the difference. Induction is we do it intentional initiation of labor before it begins naturally. Augmentation is when we stimulate the contractions, but it has to start naturally first. Bishop's scoring system. This one is in page 183, your table 8.1, looking at it. So this one evaluates the cervical response to induction procedures. After we do that induction, after we start that induction process, then we do a Bishop scoring system, which evaluates the cervical response to the induction. A high score, the magic number that you want to remember is 6. You want a higher score above 6. This means predictive of successful labor induction because the cervix has ripened or softened in preparation for labor. So if you look at page 183, your table 8.1, this is a modified Bishop scoring system. You can see the dilation of cervix in centimeters, consistency of the cervix, length of the cervix, cervical effacement in percentage, position of the cervix, and then station of the fetus itself in relate to the ischial spines. So you for the dilation of cervix, 0 is 0, 1 is 1 to 2 centimeters, 2 is 3 to 4 centimeters, and then 3 is 5 to 6 centimeters. Consistency of cervix, we also check if it's firm, medium, or soft. Your length of your cervix. Um, Remember that the goal for ripening that cervix is to dilate it and then efface it, thin it, and then you want the length of the cervix to actually shorten. Okay, so 0 for if it's still more than 4, and then 1 for 2 to 4, and then 2 for 1 to 2, and then 3 for 1 to 2 centimeters. Cervical effacement, 0 for 0 to 30%, 1 for 40 to 50%, and then 2 for 60 to 70, and then 3 for 80% effacement. Position of the cervix, you want posterior, midline, or anterior. And then station is 0 for -3, 1 for -2, 2 for -1 or 0, and 3 for +1 or +2. So again, you want a high score. You want a score that is above 6, because this means that the induction is doing what it's supposed to be doing. Successful labor induction. Indications for labor induction. So when are the times that we do or we induce labor? One reason is your gestational hypertension. So if you recall, we talked about it in class, that if it's a true gestational hypertension, the cure is actually when the mother gives birth. So after birth, that hypertension or that blood pressure will go back to normal. Another reason is a ruptured membranes without spontaneous onset of labor. If that membrane is somehow ruptured and then the amniotic fluid is leaking and the baby is actually at term, so it's time to induce that labor. Infection within the uterus, because we want to correct right away. Infection could lead to septic if it's not corrected right away. So induce the labor, correct the infection. Medical problems in the woman that worsen during pregnancy. Again, let's go back to your gestational diabetes mellitus. What if it's being uncontrolled now? All the other complications that we did talk about in class. If it's becoming worsened during pregnancy and the baby is actually term and it's okay to give birth, then induce that labor. Fetal problems such as slowed growth, prolonged pregnancy, or incompatibility between fetal and maternal blood types, and also your placental insufficiency, and then fetal death. Okay, this slide right here is one thing that is very important for us to remember. These are contraindications to labor induction. So it means these are the conditions or situations where labor induction is a no-no, right? We don't do this labor induction. 1, placenta previa. We talked about in class what placenta previa is. This is when your placenta is actually in the lower side of the uterus. It's in the cervix. Umbilical cord prolapse. Abnormal fetal presentation. High station of the fetus. Active herpes infection in the birth canal. Abnormal size or structure of the mother's pelvis, and previous classic cesarean incision. So active herpes infection in the birth canal. You don't want that baby to go through the vaginal canal, right? So that baby should have a cesarean section. So we should not induce that labor. Abnormal size or structure of the mother's pelvis. Of course, if you induce that labor, then you're gonna get ready for the baby to come out. And if the size and structure of the mother pelvis is not actually good for a fetus to come out, then we cannot do that too. Previous classic cesarean incision. Why? Because we did talk about this in class. Those mother that actually gave birth via cesarean section before is at high risk for hemorrhage. There's a high risk for that uterine scar to open up and cause hemorrhage. Pharmacologic methods to stimulate contractions. You have your prostaglandin, and you have your laminaria, your oxytocin, those things that we use and we give to the patient for to induce the cervical ripening. Cervical ripening is the physical softening of the cervix that leads to effacement and dilation. And then we also give the oxytocin. Oxytocin is to do the induction and augmentation of labor. Oxytocin is the one that helps the mother or the uterus to contract. This one is used to initiate or stimulate the contractions of the uterus. Prostaglandin, either your E2L or your E1. Your prostaglandin E2L, this is given intravaginally. This is a sustained release. It's what we call dinoprostrone or Cervidil. And I'll show you later on in the next slide. Prostaglandin E1. This one is actually either by mouth, BO, buccally, or sublingual, or intravaginally. These medications are your misoprostol or your cytotec. Preparing the woman for labor, we gotta explain the procedure to the woman. Of course, the woman needs to understand what we're doing so they are ready, they're mentally ready for what's now gonna happen. You obtain the baseline vital signs and then the fetal heart rate. You ensure that the IV line is placed. They should remain in bed for up to 2 hours. And then after we give them that vaginal insert, which is those prostaglandins and that laminaria that we did talk about earlier on for your cervical ripening and for the induction of the contraction, then you can give your oxytocin. Oxytocin induction can start 6 to 12 hours after that vaginal insert has been removed. Then we assess for signs of uterine tachysystole. Uterine tachysystole is the excessive contractions of the uterus, which is not good. If there is an excessive contractions in the uterus, there will be a fetal compromise and the uterine may rupture. Remember that every contractions, there is a reduced blood flow to the placenta, hence there's a reduced blood flow to the fetus. So if there is an excessive contractions, the contractions is very intense and prolonged, then there might be a fetal compromise. And also there's a high risk for your uterine rupture if the contraction is really, really intense and prolonged. Before we move forward, let's talk more about the tachysystole. So tachysystole is most often evidenced by contraction frequency that is greater than every 2 minutes, 5 or more contractions within 10 minutes, durations longer than 90 seconds, or resting intervals shorter than 60 seconds. This is in page 185 in that safety alert box. So what do we do when this actually happens? What we do is we notify the healthcare provider and the RN. We reposition the woman to the side position. We decrease the dose of the oxytocin, of course with the doctor's order, or we even discontinue the oxytocin. And then you increase your IV fluids, you administer oxygen to the mother, 10 liters per minute, 8 to 10 liters via a mask, because again, that excessive contraction, there's a low blood flow to the fetus, there's a low oxygenation to the fetus. So the goal is to increase that oxygen to the to the mother, so that it can also help with the fetus. And then you might, after you notify the healthcare provider, you might need to prepare a medication that is called a tocolytic drug. Tocolytic drug actually reverses the tachysystole because this drug helps reduces the uterine contractions. After you do all of those interventions, then what you're going to do is to assess that uterine contractions and then the fetal heart rate every 5 minutes to make sure that your intervention is actually working and correcting the situation. Okay, other mechanical methods that can help with induction of the labor. This time is to dilate the cervix. We're dilating the cervix. One is your stripping of amniotic membranes. So this one, the goal is to separate the amniotic chorioamniotic membranes from the wall of the lower uterine segment. What's going to happen is that the examiners or the physician with a gloved finger, they're going to insert it through the cervix and then in the internal cervical opening, and then they rotate the finger along with the lower uterine segment to kind of like strip that amniotic membranes or separate that membranes from the wall of the uterus. And then we have your hydroscopic dilators and your balloon dilators. So hydroscopic dilators is what we call the laminaria. This one is we insert it in the lower uterine segment, and this is medicated, by the way. It stimulates the release of your prostaglandin, and then the laminaria itself, the dilator itself, actually will swell inside the cervix, opening that cervix. Then you can also use your transcervical balloon dilators. What we do is we insert the 16 French catheter. You're gonna put the 30 ml balloon inserted through the cervix, and then it slowly inflates. As it slowly inflates, then there's that pressure that opens the cervix and dilates the cervix. This is a picture of your laminaria, your hydroscopic dilator. So from right to left. So the very first one to the right, that's your after 1 hour. Again, we insert it in the cervix, and then this one is actually releasing the prostaglandin, and the thing itself is actually swelling to help opening that cervix. So after 1 hour, it looks like that one, the very far one to your right. And then as the hours go by, then it's gonna swell even more on your farther left. That's how the laminaria looks like after the 24 hours. Okay, before we move forward, I just want to mention really quick, there's also non-pharmacological methods to stimulate the contractions. And as nurses, we also need to know this. Um, One is walking. So walking, actually, the pregnant women, you're gonna ask them to walk because the change in their activity, walking, it stimulates the contractions. Also, it helps with the descent of the baby by gravity to the pelvis. Another thing that we can do is nipple stimulation of labor. So if you recall, the breastfeeding itself is like stimulating the nipple, and it's actually helping, the stimulation of the nipple is actually helping to secrete that oxytocin. Same thing, same concept. You're gonna want to stimulate that nipple during labor because it's helping with the releasing of the oxytocin, and the release of oxytocin is actually helping with the contraction or stimulating the contraction of the uterus. How do we stimulate the nipple during labor? What you do is you pulling or rolling them one at a time, or you gently brush them with a dry washcloth. You use water in a whirlpool tub or a shower. You apply suction with the breast pump, or even sexual intercourse. Sexual intercourse, the orgasm actually helps with stimulating uterine contractions, and the male ejaculation actually contains prostaglandin, which is what we're talking about. Prostaglandin is actually helping with the cervical ripening. All right, so moving forward with the more obstetric procedures. Amniotomy. So what is amniotomy? Amniotomy is the artificial rupture of the membrane, or what we call AROM, artificial rupture of the membrane, the amniotic sac. This is done to stimulate or enhance the contractions, which of course further helping with the labor and delivery. It also stimulates the prostaglandin secretion. This procedure is done by a healthcare provider. What they do is they use a sterile sharp instrument to puncture the amniotic sac, and it releases that amniotic fluid for that reason, for the induction of the labor. Us nurses, our role here is to just make sure you're helping the woman be comfortable during the procedure and that they are ready for the actual labor itself. Complications that can happen with amniotomy or the artificial rupture of your membranes: prolapse of the umbilical cord. So again, once that membrane is ruptured, the amniotic sac is ruptured, then the fluid will now come out, your amniotic fluid will now come out, everything is going down. So there's now high risk for that umbilical cord to prolapse. Also, because we ruptured the amniotic sac already, now there's no membrane that is covering the fetus, so there's a risk for infection. There's also a risk for your abruptio placentae. The placenta, with the pressure of the amniotic fluid coming out from the uterus, actually can strip that placenta away from the uterine wall, which can cause your abruptio placentae. We have a picture of this prolapse of umbilical cord in our book. It's in page 203 if you want to see it. In that picture, you can clearly see that that umbilical cord is actually coming out from the cervix. It's what we call a prolapse umbilical cord before even the baby is out. Okay, so how do we correct the complications? Prolapse of the umbilical cord. This one we have to do an emergency cesarean section, because if that umbilical cord remains prolapse, remains kinked, then there's a reduced blood flow to the fetus. There's a high risk for fetal compromise. Infection. So what we do is we take the woman's temperature every 2 to 4 hours after her membrane is ruptured. And what we look for is a maternal temperature that is not higher than 100.4, because if it's 100.4 degree Fahrenheit or higher, then that suggests infection. Then also you're going to take a look at your fetal heart rate. Make sure it's in the baseline. It's not going above 160 beats per minute. Complications associated with your amniotomy: your green fluid, that's your keyword, is green fluid, may indicate that the fetus has passed meconium stool. Your prolapse umbilical cord, we just talked about. Make sure you're checking the fetal heart rate. It's not out of the normal range, which is 110 to 160 beats per minute. Infection. So once that amniotic fluid is actually coming out, what you're going to want to do is to observe the color, odor, amount, and the character of that amniotic fluid. Once you confirm it's amniotic fluid from the nitrogen paper, and then you're going to want to check the woman's temperature. You don't want 100.4 and higher. And then your abruptio placentae, which is the bleeding with pain. Bleeding with pain. So those are the things that you monitor, so that when you see it right away, we can correct it right away. Just a repetition for the non-pharmacologic methods to stimulate your contractions. You're going to want to encourage your patient to walk stimulates contractions and eases the pressure of the fetus on the mother's back. Because of the gravity, it helps with the descent of the baby. Nipple stimulation of labor, we did talk about it already. It causes the pituitary gland to secrete the natural oxytocin, which actually helps with the contraction of the uterus. Version. There is what we call version. There is external and there's internal. Version is a method that is used to change the fetal presentation. We did learn about the presentations of the baby. You have your vertex, your military, your face, your brow, breech, footling, transverse lie, longitudinal lie. So those things, those fetal presentation that we should know by now, there is what we call a version, okay? Meaning this one is we can change the fetal presentation. For example, if you have a patient that is actually, everything is going well up until they get to maybe 37 weeks or 38 weeks of gestation, and they come to the clinic and you check that the fetal presentation is actually from a vertex presentation, now it's changed to a breech presentation. So not good, right? Because that is not the ideal presentation that you would want when the baby is coming out of the pelvis. So there's method that the physician can do to change it. There's external, which is usually performed at 37 weeks of gestation, but before the onset of the labor. Okay. Internal is emergent, and this one is actually during labor. So what's going to happen is that it will be guided with an ultrasound. The procedure itself will be guided by an ultrasound. And then the healthcare provider, one hand is going to push that fetal buttocks upward, and then the other hand is actually pushing the fetal head downward. So it's either, imagine it as if it's like a clock, right? It's either you're gonna turn it clockwise or counterclockwise. But before this procedure, the woman should receive a tocolytic drug to relax her uterus during this procedure. It's because if you don't give the tocolytic drug, whenever that healthcare provider is actually touching that uterus, then it could stimulate a contraction. That's why it's very important to give the tocolytic drug. Also, the fetal heart rate is being monitored frequently during the procedure. After the procedure, it's discontinued, tocolytic drug is discontinued, and then the Rh negative woman needs to receive that ROGAM to prevent that Rh positive antibodies. And then there's risk and contraindications for this version. So remember, we're manipulating the fetus itself while it's still inside when you have your external procedure. Risk and contraindications, you might have an abnormal placental placement. You might have for those previous cesarean birth, they might have a vertical, might have that risk of opening that uterine incision or that uterine scar. And then for those that have active herpes virus infection or poor placental function, we don't want to do that and stimulate the baby. Fetus can become entangled in umbilical cord, again because we're manipulating the baby inside, so that umbilical cord can actually get entangled in the fetus. So internal, this one is the one that's happening during labor. This is more common for those twins, those patients that are giving birth to twins. So after they give birth to the first twin, right, the healthcare provider can actually insert their hand and do that internal rotation of the baby to change the fetal presentation, hopefully, so that the second baby can actually come out of the cervix um, smoothly. Episiotomy is a controlled surgical enlargement of the vaginal opening during birth. This is when we have to cut that perineum versus having a skin tear or laceration, because indications for your episiotomy, there's a better control over where and how much that vaginal opening is enlarged. You also have a clean edge, a clean wound, rather than having that ragged opening if there's a skin tear or a laceration. Also, that laceration putting the patient at high risk for hemorrhage versus if we do an episiotomy. Perineal lacerations and episiotomy, they're actually described based on the amount of tissue that is involved with the tear. The only difference is that, like we said, episiotomy is where the physician actually is the one that is cutting and making that opening wider, versus the laceration. This one is an uncontrolled tearing of the perineal tissue. So when you talk about perineal lacerations and episiotomy, we're talking about first degree, second degree, third degree, and then fourth degree. So first degree is where it's superficial vaginal mucosa or perineal skin. Second degree is where it involves the vaginal mucosa, the perineal skin, and deeper tissues of the perineum. Third degree is the same as second degree, but it involves the anal sphincter. And fourth degree is where it extends through the anal sphincter into the rectal mucosa. So looking at this, first degree, second degree, third degree, fourth degree, you don't want this third and fourth degree, right? Because the damage is a little more extensive than the first degree and second. Um, so what we do for these lacerations is we monitor the patient for the discomfort after postpartum, after giving birth. You have to treat it as if it's a regular wound that you're trying to heal. If you look at that picture in page 187, so you have two samples of episiotomy there. You have your midline episiotomy where they cut it like in a longitudinal position, and then your right mediolateral episiotomy will they cut it on the side. Okay, then between the two, your right mediolateral episiotomy and your midline episiotomy, the median episiotomy is easier to repair and heals very neatly. Okay. The other one, your mediolateral episiotomy, this one actually, yes, provides more room during the birth, but there's a high risk of scarring, and the healing is actually not as fast as the midline episiotomy. So what are the risks of your episiotomy or laceration? Again, like I just said, treat it as if it's just your regular wound. There will be a risk for infection because it's an open skin, it's an open wound. There's also a risk for the extension of the laceration. into, deeper tissue or to the nearby tissues, okay? Especially after the birth, your postpartum. What you're gonna make sure is there's not much pressure that you're putting in the perineum after birth. Okay, just really quick before we move forward for the forceps extraction. Um, Nursing care for your episiotomy or laceration for the first 12 hours, what we want, is cold pack, cold treatment, right? Cold packs should be applied to the perineum. What we want is to reduce the swelling, reduce the bruising, reducing the pain. After the 12 to 24 hours of your cold applications, what you want now is to provide them with warm treatment, your hot packs, your warm packs. You want them to be doing a sitz bath with warm water. What you want here now is to increase the blood circulation, enhancing the comfort, enhancing the healing. Okay, forceps extraction. Forceps, if you want to see the picture, is in page 188 of the book, figure 8.2. That is a picture of the baby being born vaginally with the help of the forceps. So forceps, like we said, it provides traction and rotation of the fetal head when the mother's pushing efforts are insufficient to accomplish a safe delivery. But please remember that forceps is only used at the end of your second stage of labor in vaginal delivery. In addition to that, the physician can actually use forceps also to help extract the fetal head when they are doing the cesarean birth, cesarean section. Vacuum extraction birth. Again, page 188, looking at the figure 8.3, you can see in the picture there's a use of the vacuum extractor to rotate the fetal head and assist with delivery. So this vacuum actually uses that suction, and then that suction is actually applied to the fetal head to assist the mother for the birth of the head, birth of the baby itself. And then this vacuum is only used with occiput presentation and at the end of second stage of labor. So when do we use forceps and vacuum extraction? There are some reasons that we use it. So number one is maybe the mother is tired already. She's very, very exhausted that she cannot push effectively anymore. So the forceps and the vacuum can actually help with the birth of the baby. Also for those women who has a cardiac or pulmonary disorder, so that it actually helps relieve that pressure off of them, pushing that baby out, so it can help them too. Okay, but things to remember though, before we consider using the forceps and the vacuum extraction. So the cervix must be fully dilated, 100% effaced. The amniotic sac is ruptured, and then bladder should be empty, and then the fetal head should at least be in the +2 station before we can use this forceps and vacuum. What are the risks of forceps or vacuum extraction? There might be a trauma to the maternal or fetal tissue. The mother may have a laceration or hematoma in her vagina. The infant may have a bruising, facial, or scalp lacerations or abrasions. There might be what we call a cephalohematoma, where there's like a clot that you can actually feel on the head of the baby, or intracranial hemorrhage can also happen. Okay, if you look at this picture in page 188 in the bottom, you can see that lump that actually is shaped like that vacuum extractor. That is what we call shignon. Okay, shignon. This one is a harmless area of circular edema on the infant's scalp because of that vacuum extractor where it is actually applied. That's why it's shaped like that vacuum. After we use this, so what we're gonna do is nursing care is that we're gonna want to check the infant's head. That's what you're first gonna do, is you're gonna check the infant's head for any lacerations, abrasions, or bruising. It's okay to have a little red, right? A little alteration in shape, just what we talk about your shignon. But one thing to remember that might happen when they're using this forceps and this vacuum is what we call the facial asymmetry. Facial asymmetry is when that one side of the face is not symmetrical to the other side of the face, um, because it's going to be very obvious, especially when the infant is crying. You're gonna see it. The reason for this facial asymmetry is that because of that forceps, it actually may injure the infant's facial nerve. So very important to remember when you have a patient that is actually having that forceps assisted birth, make sure that you check the baby, you check the if the facial features are symmetrical. If it's not, then there might be a damage to the facial nerve. So if that actually happens, that nerve injury, it usually resolves without treatment. That shignon also, the one in the scalp, we did say it's harmless. It actually will resolve by itself also quickly. So the mother or the parents may freak out because of the shape or the weird shape of the head. So as a nurse, it's your job to educate them. It's okay, right? It's going to resolve quickly. Or they may also be freaking out because of that facial asymmetry that they see because of the damage to the facial nerve. Again, educate your patient. It's going to resolve by itself. There's no need for any interventions. Okay, cesarean birth. So now we'll talk about the cesarean delivery, which is a surgical procedure if that fetus cannot actually successfully come out from a vaginal delivery. So what are the indications of your cesarean birth? One is abnormal labor. Two is the inability of the fetus to pass through the mother's pelvis. Maternal conditions such as your gestational hypertension or your diabetes mellitus. There might be an active maternal herpes virus, previous surgery on the uterus, fetal compromise, and then you have your placenta previa or your abruptio placentae. Preparation for cesarean birth. So these are those situations that is not really emergent, where we actually still have some time to prepare for that surgery. So we can do clinical lab studies, which are your blood draws, so we can identify anemia and some blood clotting abnormalities, complete blood count, coagulation studies, blood typing. We do baseline vital signs, including your fetal heart rate, position the woman for comfort. You insert the IV line and then you're gonna insert the Foley catheter. Okay, types of incision. There's types of incision for your cesarean birth. We have your vertical and you have your transverse. So vertical allows more room for a large fetus. Okay. And then you have your transverse, or also known as Fanon still. If you look at your book, page 190, figure 8.4. So those are some samples of types of uterine incisions for cesarean birth. So the first one is what we call low transverse incision. Okay. And then the second one is your low vertical incision. And then the third one is what we call classic incision. Okay. So for your low transverse, this one is not likely to rupture during another birth. So this is the incision that actually we would want for those patients that is actually having that VBAC, or your vaginal birth after cesarean. Okay, so that VBAC is actually possible with this type of incision. And then you have your low vertical incision. This one, the good thing about your low vertical is there's minimal blood loss. And then, however, the bad thing for this one is that it's more likely to rupture during another birth. Same thing as your classic, the third picture. This one is now rarely used because of the risk for more blood loss. And also, just like your low vertical, this one is most likely to rupture during another pregnancy. So if you recall what we did talk about from the previous chapter just before this one, if you have a patient that actually had a history of cesarean section or cesarean surgery, then the risk actually for the next pregnancy is rupture of that uterus, which can lead to hemorrhage and can lead to fetal compromise, even compromise the maternal circulation. Before we move forward to nursing care in the recovery room, let's go over the risk of your cesarean birth really quick in page 189. Let's look at the maternal risks and the risk to the newborn. So for the maternal risks, there is a risk related to anesthesia. So again, your cesarean birth requires anesthesia. And we did talk about those adverse effects that can happen when we give those medication or we give anesthesia to the patients. If you recall your maternal hypotension and all of those adverse effects that we did talk about in class. So there's a risk for related to your anesthesia, respiratory complications, your hemorrhage, blood clots, injury to the urinary tract, delayed intestinal peristalsis, and infection. And then risks for the newborn, they may include the following: inadvertent preterm birth, respiratory problems because of the delayed absorption of your lung fluid, and then injury such as laceration or bruising, and scarring of the uterus that may influence progress of future pregnancies. Okay, nursing care in the recovery room. So after the cesarean birth, please remember that this is a type of surgery. So just like any other surgery, the risk of hemorrhage and shock is high. So we monitor the patient's vital signs because it will help us identify hemorrhage and shock right away so that we can do something about it and correct the situation right away. IV site and rate of solution flow. Fundus for firmness, height, and midline position. So you don't want that soft and boggy fundus. You want a firm, you want the height is by the umbilicus area, and then it should be in the midline position, because if it is actually on the side, then that means there may be a distended bladder. Okay, checking for the drainage, the dressing for the drainage. If there's an increased drainage, increased bleeding, how often are we changing this dressing? If it's excessive change of the dressing, then there might be a hemorrhage that's going on. Lochia for quantity, color, and presence of clots. Your lochia rubra, your lochia serosa, and your lochia alba, we should know what is the characteristics of those lochias and how long do they usually last, so that we can monitor if one is actually, progressing into another one, or is actually getting worse. And then urine output from the indwelling catheter. Okay, some terminologies. So in a normal labor and birth process, what we want is cervical dilation, your effacement, the descent of the fetus. Those things that needs to happen actually is happening, right? That's a normal part of the labor and birth. A an abnormal labor is what we call dysfunctional labor. Dysfunctional labor is the labor that does not progress as we are expecting it to progress. Okay, what are the risks or risk factors for your dysfunctional labor? Your advanced maternal age, obesity, over distension of the uterus, right? Because like we did talk about, if that uterus is actually distended, you would want for the patient to empty their bladder so that the uterus can actually do what it needs to do in during labor and birth, right? Then you can also have your hydramnios, which there's a lot of amniotic fluid, or your multi-fetal pregnancy with twins, or those, or there are more fetus inside, maternal fatigue, dehydration and fear, and then lack of analgesic assistance. All right, dystocia. Dystocia is a term that we use to describe a difficult labor. Okay, dysfunctional labor is when that labor is actually not progressing. Your dystocia is a terminology that we use to describe a difficult labor. That's the difference between the two. Okay, let's talk about muscle tone. This is the one that's helping with the contractions during labor. So there might be some problems with what we call the powers of your labor or the contraction. Okay, we have hypertonic and we have your hypotonic. So for your hypertonic, there's an increased muscle tone. The contraction itself is painful, but it's non-productive. It's actually not helping with the normal process of the labor. The uterus is very tense, right? The uterus is very tense even between contractions. Remember, between contractions, that uterus should be in a relaxed state, right? Because what we want is for that blood flow to go back to the placenta, that oxygenation will increase for the baby, for the fetus. If that uterus is tense, even from during contractions and even between contractions, so how is that uterus actually relaxing? How is that blood flow going back to the placenta? How is that oxygenation to the baby? So all of that are affected because of that increased muscle tone. Okay, hypotonic, there's a decreased muscle tone. This one happens because that more likely is because of an over distended uterus. So those muscle fibers, they stretches, right? It stretches the muscle fibers, and it reduces their ability to actually contract effectively because of that decreased muscle tone. So how do we correct it? For your hypertonic, because there's an increased muscle tone and you want that uterus to actually kind of like relax. So what we do is that we can give those tocolytic drugs, such as your terbutaline. This one actually will help with um, not only mild sedation to allow that woman to rest, but it's actually helping for that uterus to actually relax also, so that it's not like doing that intense and non-stop contractions. For your hypotonic, so um, what we can do for this patients is number one, if the membranes are still intact, what the physician would actually do is what we call your amniotomy, which is the artificial rupture of the membrane. Because remember, if we do that amniotomy, then it actually helps with increasing that contraction in the uterus, so that could help. Another thing is what we when we talk about when we're giving the oxytocin, okay, that actually can help nipple stimulation, right? It can increase the strength of that contractions. IV or oral fluids also can help with the hypotonic. Very important to remember for your decreased muscle tone. One intervention that we can actually do as nurses is position changes. So you can help the patient by changing their position. Okay, it can help not only to relieve the discomfort during this labor and contractions, but also position changes actually helps with contraction, increasing those contraction, making it stronger, making it more effective. What you want is to actually ask your patient to sit in an upright position, or either lie on their side. Okay. Walking can also help with this decreased muscle tone. Again, like we said earlier on, it actually help with the contraction, for that contraction to be stronger and more effective. Ineffective maternal pushing is when the woman actually is not having that effective pushing during that second stage of that labor. That woman actually, or that patient, may not understand what technique to use for fears, or what technique to use for the breathing technique, for the pushing techniques, right? What we can do as nurses is to actually help them, especially those patients that did not have the prenatal care or did not join those classes that can actually help them prepare for labor and birth. All right, and then epidural or subarachnoid blocks may depress or eliminate the natural urge to push. We discussed this already. That's why we're looking at that monitor for the fetal heart rate and for the contraction, because those patients that actually receive the epidural and the subarachnoid blocks, they don't feel that urge to push. So as nurses, well, we're guiding them. Okay, your contraction is now starting. It's time to start getting ready to push, right? And when the peak of the contraction is there, that's when you're actually telling your patient to push, right? Another thing is that an exhausted woman may be unable to gather enough energy to push. And it's true. There are women out there, especially those preemie gravidas, those first timers, right? Their labor is very prolonged, that actually they get too exhausted, right? So again, that exhausted woman, she may not be able to gather that strength, gather that energy to actually push, right? Push effectively to help the baby to come out. Right. Problems with the fetus itself, the passenger, right? The passenger or the fetus might cause the labor's progression to be dysfunctional. Why? There are some reasons that can actually contribute to this. You have your size of the fetus, maybe too big, right? The presentation of the fetus or the positioning. Okay, other factors might include multifetal pregnancies and some birth defects. Abnormal fetal presentation or position. If you guys can recall, the most ideal one or presentation that we would want is the vertex presentation, because the smallest diameter of the fetal head is the one that's coming out first. So if that is not the case, then there might be a problem, right? There might be an abnormal fetal presentation or position. This one prevents the smallest diameter of the fetal head to pass through the smallest diameter of the mother's pelvis. Or another problem that could happen is your abnormal presentation and your abnormal position. Breech, right? Footling, transverse lie, those things. Nursing care for abnormal fetal presentation or positions. So we encourage the woman to assume those positions that actually can help the fetus to actually hopefully rotate or descend, okay, to reduce also the back pain of the mom, right? Positioning, sitting, kneeling, or standing while leaning forward, okay, rocking the pelvis back and forward while on hands and knees. This one encourages the rotation of the baby, hopefully. Side lying, squatting in second stage of labor, or lunging by placing one foot in a chair with the foot and knee pointed to that side. Multifetal pregnancy, yes, may cause dysfunctional labor. Um, it can cause those hypotonic, right? Because there's a uterine over distension. When that happens, then there's gonna be a poor contraction, poor quality contraction, uterine contraction. And then you can have also an abnormal presentation or position of the fetuses. It can interfere with the mechanism of the labor. Often one fetus is delivered as cephalic and the second as breech unless a version is done. Remember your version, right? You have your external and your internal. So for your multifetal pregnancy, most of the time, one fetus is actually delivered in a cephalic, and then the second one is actually breech. So what's going to happen is that physician is actually going to go inside and do an internal version, right? Where she's going to rotate that baby, okay? So that the head is actually the one that is coming out first, okay? To ease with the birth. Okay, we might have some problems with the pelvis and the soft tissues itself. Bony pelvis, like we talked about, gynecoid pelvis, that's the one that you want for a vaginal birth. And then soft tissue obstructions, okay? Soft tissue in the pelvis should be ready for that to have the passageway for the baby, but there might be some obstruction that can happen. Most common problem is from a full bladder. So again, what we do is we monitor and making sure that patients that is actually in labor, they're emptying their bladder, because it can actually help. There's so many things also that can um, impede or can cause a problem just because of a full bladder, and it's very easily fixable. So once you catch it, do it. Make sure that the mother is actually emptying the bladder. It can correct those issues that's happening. Most common factors that can prolong the labor and can affect the psyche of the mother is lack of analgesic control of excessive pain, There may be an absence of a support person or coach, your lack of support system, immobility and the restriction to the bed, and lack of ability to carry out those cultural traditions. So you're gonna have patients that actually are high believers of their own culture, and honestly, if they're not like able to do those rituals or things that they're actually um, following their culture traditions, actually that can affect the psyche of the mother, and that actually can affect the labor process itself. Okay, so when that psyche of that mother is actually affected, so there they will be anxious, right? There will be increased anxiety. And then when there's an increased anxiety, the body actually responds by secreting those hormones. Remember, stress, right? Increased stress, increased anxiety. Hormones are actually being secreted from the body. You have your cortisol, your epinephrine, and your adrenocorticotropin hormone. However, the problem with that is that these hormones are actually reducing the contractility of the smooth muscle of the uterus. That's one effect of this hormone that are being released. Okay, so now the problem starts. The body's gonna try to compensate. What it's gonna do is the uterus now is gonna start using more glucose for energy. Okay, then it's gonna divert the blood from the uterus. It's gonna increase tension of pelvic muscles and can impede the fetal descent, hence prolong the labor. It increases also the perception of pain. Again, when we talked about pain, right, what we said is we want to control that pain to help them actually have a smooth labor process, smooth delivery. Because if there is stress, if they're tense, there's hormones that are being released, there's an increased tension in the pelvic muscles, increased perception of the pain, then that labor is not progressing smoothly, it can prolong that process. Okay, a Friedman curve is a graph that we often use to show the progress of the cervical dilation and fetal descent. So we use this is a guide to assess us and to manage the normal progress of the labor. Okay, prolonged labor. This one can cause several problems, okay, including your maternal or newborn infection. The mother might be really exhausted already, your maternal exhaustion, and there's a high risk for your postpartum hemorrhage and greater anxiety and fear. Precipitate birth. So, precipitate birth is a birth that is completed in less than 3 hours. So, everything begins um, abruptly, everything happens quickly, right? The labor begins abruptly and then it intensifies quickly. The contractions, they are frequent, they are intense, um, they progress fast. The problem with this one is that everything is happening so fast that uterus might not be as ready as it is in a normal situation, right? There may have a uterine rupture. There may have a cervical lacerations even or hematoma. Um, and because everything is so fast, there's no normal process of your contraction and interval and then contraction and interval, so your fetal oxygenation actually may be compromised, and then you might have a birth injury. There may be some kind of injury because of um, that rapid passage through the birth canal. Everything is happening so fast in your precipitate birth. Okay, even though some might think, oh, this is good because it's short, it's quick. Yes, it's true, but there may be a risk for injury because everything is happening so fast, faster than how it should be. All right, birth injury can occur. Injuries can include your intracranial hemorrhage and nerve damage. Okay, premature rupture of membranes, or your PROM, which is different than your AROM earlier, right? Your artificial rupture of membranes. This one is premature rupture of membranes. So this one is a spontaneous rupture of membranes at term more than 1 hour before labor contractions begin. So in this PROM, the first thing that happens is the rupture of the membrane, right? When we did discuss the stages of your labor, and we were talking about that first stage. So usually, what needs to happen is that mother is actually going to have that contraction, that pain, maybe some bloody show, mucus plug needs to come out, right? All of those um, things that is actually happening usually in the stages of labor. With your premature rupture of membranes, there's actually a rupture of the membranes before the labor contraction even begin. Okay, vaginal or cervical infection may cause your premature rupture of membrane. Okay, infection may cause PROM. How do we confirm? It's if it's amniotic fluid, we do a nitrogen paper test, and then we look for a burning pattern from the vaginal fluid placed on a slide and then viewed under the microscope. It's just a pattern that you could actually see in a microscope when an amniotic fluid is actually put in a slide and viewed under a microscope. Patient teaching for a woman with infection or in preterm labor. So you tell them, right? You tell the woman, or you monitor it yourself if you're the nurse that's taking care of the patient, to take their temperature. What we don't want is a temperature that is above 100.4 because that may indicate infection. Avoid sexual intercourse or inserting anything into the vagina once you have that premature rupture of your membrane. Avoid orgasms, avoid breast stimulation because these can cause contractions. Maintain any activity restrictions as prescribed, and then note any uterine contractions. Reduce fetal activity and other signs of your infection. Record and also check for the fetal kick counts daily and report fewer than 10 kicks in a 12-hour period. Preterm labor. Preterm labor is the labor that occurs after the age of viability after 20 weeks but before the 37 weeks of gestation. Okay, the main risks are the problems of immaturity in the newborn. Okay, because that's why it's called preterm. All right, some risk factors for your preterm labor: exposure to this medication, your diethylstilbestrol or DES, underweight, chronic illness, dehydration, preeclampsia, previous preterm labor of birth, previous pregnancy losses, substance abuse, stress, infection, anemia, preterm, premature rupture of membrane, inadequate prenatal care, poor nutrition, low education level, poverty, smoking, and multifetal presentation. These could be causes or risk factors for preterm labor. Signs of impending preterm labor. So you're going to have a shortened cervix on ultrasound of 20 weeks of gestation. Okay, this may be a sign or predictive of preterm labor. Then you're going to check if there's actually some cervical effacement and dilation. And then there's what we call a fibronectin test. So fibronectin is actually a protein. This is produced by the fetal membranes. What happens is that if you have a preterm labor and this fibronectin actually leaks into the vaginal secretion, um, if the cervical effacement and dilation is actually happening, the presence of the fibronectin in vaginal secretions between 22 and 24 weeks of gestation is predictive of preterm labor. There will be maternal symptoms of preterm labor that mother is actually going to have, that those feelings that actually may be suggestive of a preterm labor. So contractions that may be either uncomfortable or painless, feeling that the fetus is balling up frequently. They might have cramps, low back ache, that pelvic pressure, or that feeling that the fetus is actually pushing down. There may be some change in the vaginal discharge, cramps with or without diarrhea, pain or discomfort in the vulva or thighs, or just feeling, that weird feeling, having that weird feeling, just feeling bad or coming down with something. Okay. So the goal for your preterm labor is to stop contractions, stop that uterine contractions. So you want to actually stop that labor as much as we can, right? As long as we can, okay? Keep that fetus in the utero until that lungs are mature enough to adapt in extrauterine life. That's the goal, okay? Keep them inside as longer as we can. We might give those medications, your magnesium sulfate, beta adrenergic, terbutaline, calcium channel blockers, or nifedipine, and your prostaglandin inhibitors. Okay. Contraindications for your tocolytic therapy: you have your preeclampsia, placenta previa, abruptia placentae, gestational age over 37 weeks, your chorioamnionitis, which is infection of the water bag of water, and then your fetal demise. Initial measures to stop the preterm labor. So the goal here is to actually stop that preterm labor. Keep that fetus inside as long as we can, okay? That's why if it's we gotta know what the reason is so that we can do something about it. For example, if it's infection that is actually causing that preterm labor, then identify it and treat it. Okay. We can also put that mother in bed rest, like activity restriction, and then you can also hydrate them. Hydration, IV fluids, increase PO fluids. And if it appears that a preterm birth is actually inevitable now, we can't stop it anymore, right? So it needs to happen. What we're gonna do is we're going to give the woman steroid drugs, your glucocorticoids. That glucocorticoids will help fetal lung maturity, especially if the gestation age is between 24 and 34 weeks. Okay, your glucocorticoids, your steroids is usually given together with a tocolytics, and your betamethasone it may be administered into two intramuscular injections, which are 24 hours apart. Prolonged pregnancy. Prolonged is where it lasts longer than 41 weeks. Okay. What are the risks of the prolonged pregnancy? A lot, there might be a placenta ages. Um, the placenta will be too matured, right? And then the fetus actually will continue to grow. The meconium actually may be expelled already. Low blood glucose levels in the fetus. And then just to add it there, the placenta ages. So it delivers oxygen and nutrients to the fetus less efficiency when that placenta is actually matured or ages. The fetus may lose weight and the fetal skin may start to peel. Tests that are used to confirm the diagnosis of prolonged pregnancy, in addition to you counting that estimated delivery date and that LNMP, right? We can do a non-stress test, your amniotic fluid index, biophysical profile, and then the kick counts of um, the baby. Okay. Some emergencies that could happen during childbirth. One is prolapse umbilical cord, and the picture is actually in page 203 if you want to see it. So there's different types also of your prolapse umbilical cord. You have the complete, you have the palpated, and you have the occult. Okay, complete is where the cord is visible at the vaginal opening. So as soon as you put that mother in a lithotomy position, they could see it right away, right? The cord is very visible. Palpated is when the cord cannot be seen, right, but can be felt as a pulsating structure. That is your keyword. Pulsating structure when a vaginal examination is done, right? So again, your mother is gonna come in for an examination. She thinks, she's in labor, put her in a lithotomy position. That physician is actually going to check for the cervical dilation and effacement, and yet when they insert that finger, they feel a pulsating structure in there during the vaginal examination. That is what we call palpated prolapse umbilical cord. Okay, occult. The prolapse is hidden, and this cannot be seen or felt. Okay, however, we can see it because we are monitoring your fetal heart rate, right? Remember your veal chop. Continuing for your prolapse umbilical cord, what are your risk factors? There are risk factors for your umbilical cord in addition to what we just talked about with your premature rupture of membranes, right? You can have also in page 203 your risk factors. The fetus is high in the pelvis when the membranes rupture. The fetus is very small, as in prematurity. The fetus has an abnormal presentation, such as footling breech or transverse lie, or there may be an excess amniotic fluid that is present. Okay, those are risk factors for a prolapse umbilical cord. Okay, placenta accreta. That's ACCRETA, accreta. This one is an abnormal attachment of the placenta to the uterine wall. Okay, placenta accreta is an abnormal attachment of the placenta to the uterine wall. This is different from your placenta previa, okay? Placenta accreta is where that placenta is attached too deeply into the uterine wall, okay? This is common, not very. It is common in women with previous cesarean section delivery, those women with fibroids, increased maternal age, and if there's like some defects, endometrial defects. How do we know when placenta accreta is happening? There's some symptoms. Symptoms include profuse bleeding. Okay, and because of that, Nursing responsibilities include monitoring the vital signs, right? IV therapy, observing for any signs of hemorrhage and shock so that we can be ready for blood transfusion if it's needed. All right, and then you have your uterine rupture. Um, Types of your uterine rupture is you have your complete rupture, incomplete rupture, and your dehiscence. So complete rupture is where there's a hole in the uterine wall into the abdominal cavity. That's why it's called complete rupture. Incomplete rupture is when there's a tears into a neighbor structure such as your ligament, but not all the way into the abdominal cavity. Dehiscence is where that old uterine scar actually starts to separate or open up. Okay, very common with your VBAC, your VBAC, right? Your vaginal birth that is actually had a cesarean section before. Okay. Amniotic fluid embolism happens when the amniotic fluid with its particles, your vernix, fetal hair, sometimes even the meconium, accidentally enters the mother's circulation and it causes this embolism, which is typically obstructs the small blood vessels in the lungs. It is characterized by that abrupt onset of that low blood pressure. Your patient is going to have that respiratory distress and some coagulation abnormalities. Treatment for your amniotic fluid embolism is mechanical ventilation. We might need to give that intubation, that respiratory support to the patient as necessary. Treat shock with electrolytes and volume expanders. And then if there's some problem with the coagulation factors, replace it. Replace those coagulation factors such as your platelets and fibrinogen. PRBC or your packed red blood cells, sometimes we need to give it. You monitor the intake and output closely. Most importantly, you're going to check the pulse oximetry because we did say that there's going to be a respiratory depression or there might be a risk for the respiratory depression. So you're monitoring your patient's pulse oximetry, you're monitoring the cardiac monitoring, and then if most of the time, yes, we're going to transfer them to the ICU because they are very, very sick patients. Okay. And that concludes Chapter 8, which is nursing care of women with complications during labor and birth.